So let's start this session. I'm going to start on this session. I actually requested that we shape these principles first, because once we understand the principles, we can go ahead. Greetings from my healthcare hospital in Goa. So we all know that Charcot disease is a very dynamic disease, and it can sort of go from one stage to the other. And even in the coalescent stage, it can go back into the inflammatory stage. It's also important to understand which part of the foot gets affected by the Charcot foot. But midfoot is more common than the hind foot. This is one Schom's classification, which really is a very clinical classification, which makes you understand how bad the deformity is based on where the mid-tarsus is in the coplanar area. It is very important to assess the deformities. Now there can be fixed deformities because of the bony changes. There can be dynamic deformities because of the TA contractures and the contractures of the tendons. You have to look at bony prominences because those are the harbingers of the next ulcer and breakdown of the skin. You have to look for the hindfoot equinus, for hindfoot varus, and forefoot abduction deformities. Why these deformities are important? Because when you do a very marked deformity correction, closure of the wounds can be a big problem. It is very important to assess the deformity radiologically. It is also possible that you can have a 3D model and try to understand the three plane deformities. But the Meary angle and the calcaneal pitch are those two major things which you have to look at in order to understand which part of the foot is broken, whether it is the navicular-cuneiform or the more Chopard's joint. Now we have a range in Charcot. We have the good, bad and ugly, but the big problem is the delayed bone healing and infection, altered bone healing, decreased bone density, a very poor soft tissue envelope, and a recurrent progressive fracture pattern. So it's like a Pandora's box. The general approach is, if it's an acute Charcot, you can just offload it with a total contact cast. If it is a chronic Charcot which has got silent, you can put a total contact cast and convert it into a grow wound and then just protect it from preventing any deformities. The moment you have an ulcer, then you have to start guiding it. You have to do an exhaustectomy, do a TA lengthening if there is a 4-foot drop, and then proceed to a total contact cast. But once you have a chronic Charcot with a deformity, then corrective osteotomy and arthrodesis is important. If you have infection along with that, then staged reconstruction or with an X-fix is the line of treatment. We know all that total contact cast is the sort of the gold standard when there is no wound breakdown or there is a limited wound. But moment you are looking at reconstructing the foot, you have the other options. Now, why does the pendulum go towards an aggressive approach? Whenever there is a severe instability of the foot and ankle, a varus or valgus deformity, an acute dislocation of the foot, infected long-standing and recalculated ulcers, or a failure of conservative treatment, you start looking at reconstruction. In the surgical principles, generally you have to optimize the preoperative status. You have to do a sequential deformity correction by planned bone resections, plan your flaps, use of VAC whenever there is an inability to close the wound. Start with the hindfoot stabilization and then progress to midfoot, and offloading it for minimum 3 months and whatever time it takes. And sometimes you can add an autogenous bone graft, or you may also use antibiotic-eluting injectable bone grafts in presence of infection. Now, in the principles of osteosynthesis, deformity correction is something that has to be done by appropriate wedge resections and soft tissue releases. And the key is a durable, long segment rigid fixation with optimal bone apposition. This is the key, because if you do not achieve this, you are not going to have a successful union. What we aim to do is a stable plantigrade ulcer-free foot, which allows full weight bearing in a surgical shoe. And we have found that overcorrection of the Meares angle gives the best 10-year survivability. Now, Samarco in 2009 gave us these principles of what we need to do in the Charcot foot. One thing is very important: we have to extend the fusion beyond the zone of injury. The bone resection is to allow for adequate reduction of deformity. The moment you remove a lot of bone, then the soft tissue closure becomes easier and there's less tension on the wound. The strongest device that can be used and which is tolerated with a proper soft tissue envelope, and position those implants where there's a maximum mechanical advantage. So deformity corrections, you have to know that you have to do a tail release, you have to do a posterior tendon release, sometimes a peroneal tendon release. Those releases are important in order to achieve your correct fixation. If you do not reduce those fractures, you will not be able to put the screws exactly where you want them to go. So good capsular release, good gastroc release, you can sometimes do a Hoag's triple hemisection, release of all those tendons will help you to get a good bony apposition. Now, In Charcot, you need a particular type of Charcot specific fixations. You could use beam screws which will X from 6.5 or 7 or sometimes 7.5 depending on the size of the bones. You can also use the locking plates, low profile with locking options and which span the joints. Sometimes you can use in a hind foot, you can use a retrograde nail. Combining with a circular external fixator is an option when you are looking at stage fixations. Antibiotic coated iron nails help in controlling infections. Beam screws through titanium mesh improve your hold to the bone. Now, as I said, positioning of the implants for better stability and additional compression screws are always welcome. More is less in Charcot. And combining iron nail with external fixation has shown to improve the survivability and better union rate in the hind foot pattern. Now, there are certain deformity patterns that you have to look at. You have this typical rocker bottom and forefoot abduction. Then you have the dorsal subluxation dislocation pattern and a forefoot adduction. The rocker bottom is the most common. And then you have the hind foot Charcot, which is either varus or varus. In the forefoot abduction pattern, you have to have a dorsal-medial culinary incision. The wedges are plantar and medial based. You have to start slow with the osteotome, and especially curved osteotomes. You should have a very gradual closure, allow a good bone apposition, and then get your fixation whichever you want to. If you can combine a beam screw with a plate, that is still better. And you have to span from the talus to the first metatarsal shaft. Then you have the dorsal subluxation patterns, which can occur in both the columns. Again, here, resection of the overlapping ends and generous subparietal release will help you to reduce the deformity. Removal of extra bone judiciously. Do not remove too much, but remove exactly what is required. And then use 2 screws, or you can use along a plate, and additional plate column fixations are desirable. In the forefoot adduction pattern, it's just the opposite of abduction, so lateral column lengthening, lateral base sections, and a bi-column fixation. It is try to aim for both columns. You have to understand in the foot, you have the stable medial column and the mobile, but in the Charcot foot, you need to stabilize both the columns. In the hind foot, you have the 3 typical involvements, the tibial involvement, the talar involvement, and the peritalar collapse. Now, this is really something that you have to plan, because your approaches will be depending on what sort of involvement is there. A hind foot nail usually helps you to manage the problem easily, provided you have controlled the infection. You could also add, along with the hind foot nail, a derotation plate in the front, because sometimes the rotational component cannot be, because of the poor bone quality, you can add some plates. In the hind foot varus approach, the translateral malleolar approach provides access to the ankle and subtalar joints. You can also add a small anteromedial approach in order to clear the medial cutter. In the valgus, the major incision is on the convex side of the ankle and a smaller incision on the subtalar joint. So you can use 2 incisions, but the major incision is to be your workhorse, and another incision on the opposite side just to achieve whatever you want to do. Using external fixations is very important in Charcot, especially in terms of poor bone quality, especially morbid obesity, ulceration and compromised soft tissue, acute infections.
Sir,
where you have to, yes,
30 seconds.
Yes, acute correction for smaller deformities and slower correction for larger deformities. That's my last slide. And so in outcomes, one of the studies showed that whether you use internal fixation or external fixation, no single technique demonstrated a significant benefit over the others, but you have to use everything in combination. Overall bony fusion rate, though it is 86.1%, it's good enough in a Charcot. You are not always achieving a bony union. Even a fibrous union is good enough to brace the foot. Complications can be attributed to the technique itself, and the pre-construction amputation was only 5.5%, with 91% apparently returning to ambulation. Thank you very much.
Call upon Dr. Saurabh Jain sir to speak on addition of lateral column shortening to differential distraction in treatment of neglected CTD.
All of here are orthopedic surgeons and surgeons rather than. The most common question after applying an X-fix, patient comes is, can anyone say, ये जंगला कब निकलेगा? So with that aim to cut short the time of frame, and the problem with children, X-fix and Elizero is they keep on hitting the foot to the floor. So your assembly keeps on loosening and breakage. So with the aim to cut short that time, what we did is added the lateral column to differential distraction in treatment of neglected rigid CTV. So fine. So introduction, CTV is one of the commonest clubfoot deformity. Primary treatment, we all know it, the Ponseti method, but there are some foots which are rigid, neglected and relapsed, which need surgical treatment. There are various surgical procedures and these depends on age, deformity and the severity. These are the rigid CTV when the Spirani score is more than 4.5. Neglected is when the patient comes after the walking age, and relapse is when the recurrence of deformity is there. We all agree that when these rigid relapse CTV present to us, we need something fixations like Joshi's external fixation system, which is proven method for these types of presented cases. So the principle is the controlled gradual differential distraction, but it is criticized for long duration of treatment and intolerance by the child. So what we did is we combined it with the lateral column shortening. Operating protocols were same for all the patients, like suitable anesthesia, supine position without tourniquet. I come to that lateral column shortening and just application in next slides. So for lateral column shortening, 4 procedures are prescribed. That is the 4 hours method, that is wedge resection of the calcaneum, anterior resection Ritbau's procedure, calcaneocuboid resection, and then Jonen procedure, lateral column excision of the cuboid. So what we followed is Jonen procedure because it's a joint sparing procedure, easy procedure, and calcaneum is undone because we are passing wires in the calcaneum. For lateral column resection, this is the procedure we followed. On the foot, we marked in the C-arm, the cuboid is marked. 2 K-wires are then passed, making a lateral wedge. These are K-wires is passed, and this lateral wedge is removed from it. These are some clinical photos of intra. For JES application, number 1, the tibial wires are passed, then the calcaneum wires are passed, and then the metacarpal wires are passed. And then this is how the intra picture shows, and then this is converted into holds. So tibial hold is made by connecting a Z plate, and the L rods are connected to make a calcaneum and metatarsal hold. This is how holds are created. Now you connect these holds to make connections. So connections are made between tibia, metatarsal and calcaneum. So on the distractors are applied on the tibiocalcaneal and the calcaneal metatarsal, and the static corrections are made on the tibiometatarsal holds. So these are holds. And then post-operative protocol. After initially 2 weeks, we leave this with compression. We don't start the distraction of the after 1 week. Because we have done the resection is being done. So for 2 weeks we leave that, and after that 2 weeks we start differential distraction. Medially 4 times and laterally 2 times, 1/4. And distraction is continued till deformity is corrected. And after the correction of the deformity, we apply the cast for 3 weeks. These are some of the cases. This is that application of JES fixator along with the incision of lateral column where the section is being shown. That's at the time of suture removal. And that's the other case, bilateral CTV, and the vessel section has been done. And that's the incision of lateral section. And this is the final X-ray, final clinical photograph of the patient. This is again a case, bilateral JES application with lateral column shortening. That's the final clinical photo of the patient. This was treated with cast, which went into failure. Then we applied a CTV, JES and distracted, and lateral column shortening was done. That's the final. On the left side, lateral column shortening was done, better correction was obtained, whereas on the right side only JES application was done. See, you can see cosmetically accepted better fit on the left side rather than on the right side. This is case 5, case 6. So I come to my result slides. Total we have operated 30 fit in 18 child. The male to female ratio was 7:2. Total 12 were bilateral, 3 right and 3 left. Mean age was 5.3 years. and mean follow-up was 2.6 years. In final follow-up, mean Pirani score was improved from 5.3 to 0.8, but these were elder child, so Pirani score is not valid for these elder child, so we evaluated our score with Farah et al. Score, and 26 patients had good to excellent results. Mean just assembly time was 12 weeks and distraction time was 6.3 weeks. When we compared our most common complications with spin tract, infection and edema. When we compared our results, we found that we could reduce the week by 2 weeks. Mean assembly time we can reduce by 2 weeks. So I conclude this by adding a lateral column shortening to the chest, we can achieve plantigrade, supple, cosmetically acceptable foot. It prevents forefoot adduction recurrence. Differential diffraction prevents shortening, and by combining, we can reduce the time for assembly in place. I thank everyone for patient listening.
Thank you, sir.
Hello, good morning everyone. Good morning. My talk for today is use of Elizaro ring fixator for ankle fusions. For conventional ankle fusions, we prefer an open method or an arthroscopic method. But in cases where there is complex ankle fusions or patients with delayed healing, bone loss, poor quality of bone, poor soft tissue cover, and adverse lifestyle, we would like to use the Elizaro ring fixator. As we know, it is a versatile construct, and with this fixator, infection, non-union deformities can be corrected simultaneously as well. So for ankle fusions, we can use Elizaro for failed ankle fractures, infected ankle arthritis, infections, deformity corrections, limb salvage in case of trauma, and neuropathic joint like Charcot. The aim of Elizaro here is to eradicate the infection completely and to give the patient a stable, pain-free ankle below the knee joint. I would generally do the surgery in a supine position or a floppy lateral position. The approach is generally anterior or a lateral approach, or wherever the sinus is present, to debride the sinus as well. The joint is prepared by denuding the talar and the tibial cartilages with a curette or with a sharp osteotome, and the joint is aligned very well. So here, after preparing the joint, first I pass a K-wire from the calcaneum to the talus to the tibia in order to align the entire joint well, so that construction of the Elizaro frame around it is easier and we don't have to struggle with the alignment while passing the wires. The fixation can be done with a 3-ring Elizaro construct or a 4-ring Elizaro construct if I am planning a lengthening in a later stage. So the first ring in a 3-ring construct is a mid-tibia ring. I generally put 1 wire, 1 shank spin. The second ring is near the ankle joint with 3 wires, and if needed I put 1 shank spin as a drop fixation, and the third ring is a 5/8 ring with 2 crisscross calcaneal wires and 2 crisscross talar wires. So the talar wires will compress the talus against the tibia. They will protect the subtalar joint, and sometimes I have put a 4-foot ring to aid the stability. Post-op protocol, the patient is asked to weight bear as early as possible. They are generally comfortable. Analgesic support is started as and when needed, and at every follow-up I check the tension on the pins. So in this system we can give a compression distraction cycles depending upon the gap at the fusion site. And if there is pin tract infection, I generally use gentamicin injections and calcium and vitamin D supplementations. So Elizaro will give a good stability, the infection is completely eradicated, limb salvage is possible, patient can walk as soon as possible, and post-operative adjustments can be done in order to correct any deformity which is persistent, and translation devices can also be used. So in the 14 cases that I have done, 9 cases have had a good successful fusion. 2 cases did not achieve fusion, but I accepted a fibrous union in such cases. But 3 cases are still undergoing treatment and they are showing good fusion rates right now. So later on I will be removing their fixator. But with Elizaro we do have a few hurdles like patient compliance. The treatment can go as long as 9 months, 10 months. So we have to counsel the patient beforehand. Pin loosening is common. Infections might reoccur superficially, which has to be taken care of, and calcaneal wires do hurt sometimes while walking. And in certain old patients, managing this fixator can be quite cumbersome. This is the first case of a 30-year-old male, and this was a sequelae of septic arthritis. He had a calcaneotibial wire put and we had to remove it, and this was the skin picture. We debrided it and put antibiotic beads, but the infection was not that controlled, so we went ahead with fusion with a 3-ring construct. We debrided and we went from the lateral side with a fibulectomy. After 5 months it went on to a good union. There were superficial sinuses, but we debrided them. This is a case of a compound ankle fracture where there was partial talar loss and contaminated wound. So here too we did a partial talectomy and tibiocalcaneal fusion was done, and after 5 months he had a good union, he is walking comfortably. This was a very interesting case of a 72-year-old female. She had a Charcot neuroarthropathy, and with a very trivial minor fall, she had a fracture, and which went on to an infection because it was neglected for 5 months. And here also we did a talectomy because the talus was completely necrosed, and we could not keep the fixator long enough for this patient because she was very old, she was not compliant to the treatment, so we had to accept the fibrous union. This is a very interesting case of a cricketer who had a ghastly accident, who was treated elsewhere with an Elizaro fixator, but it didn't go well. So she came to us to avoid an amputation, and we did a fusion. It was a tibio-talar fusion because we had to resect almost 1.5 centimeter of the distal tibia, and we inserted colistin with stimulant for this case because it was severely infected. And first I applied 3-ring construct, but later on I did a 4-ring construct because I wanted to do lengthening, and I have done almost 4.5 centimeter of lengthening, and the ankle is showing good callus, but this fixator is yet to be removed. I am still giving it some time. And this is a case of a failed ankle fusion, and it was badly infected, so we had to revise it with Elizaro fixator with a foot ring as well. And this is the case of Dr. Ruta Kulkarni, and she did a very nice job of, with good fusion after 4 months. This is the last case of an ankle arthritis with a 50-year-old male. He had a fibular osteomyelitis with a non-healing ulcer on the lateral side. So we debrided it, went from the lateral side and did an ankle fusion with 3-ring construct again. And after 6 months he had a good fusion. So patient is walking comfortably now. So Elizaro fixator can be used for complex ankle fusion, but apt case selection is very important. Do not hurry with an Elizaro fixator to remove it because the patients can be quite irritated after some time. The alignment of the foot should be focused upon while operating, and patient counseling is very important. Thank you.
So your case is the fibula was intact. So without cutting the fibula, how you can go to? Yeah.
Supplemented by the fixator?
I haven't done that yet, but we can maybe remove the fixator and put 2 screws after the infection is controlled to reduce the fixator time.
Why would you want to put a C?
Patients come with tight endoachilles or tight calves. Have you thought about a gastro-soleus recession in any of these cases?
You missed the first lecture.
Sir, in one case I have done that because the ankle was, but we are fixing the ankle. So, and then many of the cases I have to resect much of the talus and the tibia. So the gastroc became loose anyway. So I did not release the gastroc in those cases, sir.
So if you actually correct the
I have done this presentation as a case-based presentation where what are the indications of ring fixator in foot and ankle condition. Let us see. So why do we need a fixator? Majority of the cases who come to us for Elizaro fixator, they are in advanced stage of foot and ankle disease or with the negative consequences of previous surgery. In view of this, the last resort situation or any complications, we can consider advantages of Elizaro over overlooking the disadvantages and complications. So let us start with the hind foot, then we will go to midfoot. Hind foot, this was a case of post-Volkmann's ischemic contracture. He came to us with this much of equinus deformity. Sorry, I couldn't put the pre-op picture in this. So this was immediately after the frame was applied. In any case of deformity correction around the foot and ankle, the hinges placement becomes very, very important. And where do we keep the distraction? So here we can see that the hinges are at the level of the ankle joint and posteriorly we have to place a distractor. So this was after some amount of correction which he got along with triple hemisection of the tendoachilles. So later on, because after this I was not able to get more correction, I thought of doing a supramalleolar osteotomy. Again, hinges placement becomes very important. Sorry. So here we can see the posterior unit is a distraction unit. Here the hinges are placed at the level of ankle joint. Here we can see the distraction unit exactly has to be in the center from end on view. So the frame has two parts, the foot and the leg part, and the hinges have to be placed exactly at the ankle joint. Another, let us go from sagittal to coronal deformities. This was a post-infection sequelae where the plafond was in valgus, the lateral malleolus was shortened. I went ahead, did a osteotomy rule 1 for the lateral malleolus, got the lateral clear space back, and for pylon, I did a osteotomy rule 2 supramalleolar osteotomy and started distraction. So I could achieve very good correction in this case. I got the distal angles right. Now patient is ambulating well. A video please. Yeah, patient is ambulating well. We can't make out which side was operated. So let us see, this is one of my difficult case. So this patient had an open calcaneum injury, no calcaneum left, only talus was left, no heel over the talus, only midfoot and forefoot was left. There are no arteries in the foot, only collaterals were remaining in this patient. He requested me to salvage the foot. So what I did is I went ahead and planned a translational osteotomy in him so that the sole of midfoot becomes a hindfoot in him. This treatment is still undergoing. I will show you the follow-up pictures. Initially I did a translation osteotomy. Later on, this is the picture of the ring fixator. There are 4 rods, we can see 1, 2, 3, 4 I have marked here. The translation shall occur posterolateral direction, gradually 1 mm per day, and this was pre-translation, this was post-translation. The midfoot and forefoot sole is almost gone back. Patient is really happy and he is doing well. I will be removing the fixator after 3-4 months. So this is from the lateral view. Arthrodesis I don't have to go in detail because Dr. Madhura has already covered it. So I will quickly, this was a hereditary sensory motor neuropathy patient where amputation was advised in most of the places. I went ahead, I did a debridement, put a fixator and put a VAC for her. It united. I achieved a bony union in this case. Patient is ambulating well. So another Charcot deformity, this was a peritalar dislocation where I put a fixator, achieved the deformity correction, but I went ahead and did internal fixation in her. So I got a plantigrade foot. For trauma, of course, for pylon fracture, nothing much to say about it. Bad skin condition, we do apply ring fixator. We can achieve very good union. So this is after union. So malunited pylon, we can do supramalleolar osteotomy. This was a schizophrenic patient. He didn't wanted arthrodesis. So I was told to do a supramalleolar osteotomy in this case, and he did well. Another, I think Arya Agarwal sir will be telling a lot about the CTEV correction. So I will move quickly. This patient, initially I did a soft tissue distraction, but completely I couldn't get because of flat top talus, the equinus was not getting corrected. So I did a V osteotomy in this patient. We can see hinges placement in V osteotomy becomes very important. The calcaneum has to come down, so hinge placement will be inferior. The foot has to go up, hinge placement superior. So we can see two hinges here, the inferior one and the superior one. So over a period of time, we got a plantigrade foot like this. So this is the follow-up picture. Midfoot, this was a case of midfoot Charcots with a rocker bottom. If we can see her x-rays, the forefoot is already gone up, translated superiorly. I went ahead with a ring fixator application. This horizontal connecting rod will translate the metatarsals anteriorly, and the posterior distraction unit will give me the equinus correction after triple hemisection. So this was at the end of correction. We can see the arch getting recreated, the heel, wound getting healed, but unfortunately she did not come back to me. She has got treatment done elsewhere. Another indication is transverse tibial distraction. This is one of my case where internal fixation was done, but it landed up in disaster because she had atherosclerosis and blocked arteries as well. I went ahead, did a transverse tibial distraction. In this case, after 15 days, the patient started compressing it again, so X-rays may not have a distraction in this case, but the wound went on to heal really well. This was the only chance I got to salvage her limb. The mini external fixator, nothing much to say about. We use it more often for even metatarsal fixation or any infection to keep it distracted. So this is tuberculosis of navicular. After distraction, I have put an internal fixation. So another indication is joint distraction arthroplasty. I have done in one case of osteochondral defect of talus, where I have distracted and kept. So other indications can be metatarsal lengthening or lengthening of stumps of the foot, post burns contracture as well. So take home message is Irizarv is a very versatile tool, can be used in many conditions of foot and ankle. Pre-operative planning is necessary and it needs a long learning curve. Thank you.
So good morning everyone. The topic is limb salvage in Charcot foot. I talk about all failed treated Charcot foots here mostly. So all this people have already spoke about. So now we'll go straight away into the suboptimally treated cases or which were neglected Charcot. So we talk about only stage 3 and stage 4. So what are the modalities of treatment for Charcot? You have is internal fixation, you can put a beam screws, you can do TTC or an external fixator. So what are the cons of internal fixation? Risk of infection, prolonged knot weight bearing, stage procedures you have to do, higher cost incurred, and risk of implant failure and its consequences. Why Irizarv ring fixator provides a high level of stability, enables early weight bearing and walking. The construct can be altered or changed if and when required, can be done at any stage of a Charcot. Easier treatment of infection can be done immediately after removal of older or a failed implant. So there are a lot of papers published, closed arthrodosis and infected neuropathic ankle. Here they say about closed arthrodosis, I mean even without debriding the cartilage, papers have been published where you get about 81% of fusion, and in an open arthrodosis is 84.6% of arthrodosis you get. Here there is another paper saying early weight bearing can be allowed in an external fixator, or it is not possible with an internal fixation. Normally they start weight bearing in 4 weeks of external fixation, whereas in 12 weeks it is required for a patient who has undergone a beam screw or a plating. And external fixator in Charcot is one of the successful salvage methods, where you have about 94.9% external fixation gives you results of union rate when you compare it with 84% of internal fixation. So what are the advantages of Elizarov fixator in a Charcot? Everybody has talked about it. So next is, when you get a case like this, when they have done a beam screw fixation, patient goes in like this, what are your options? Whether you will refer it to a higher center or refer it to your best friend. This is another case where they have done a plating with a 9-foot nail, it is broke. This is another case they have done plating, that also has gone. So now what will you do? What are the options in your hand? Whether you are going to keep them on TCC or again do a beaming, or if ORI fails, you are going to do a limb salvage or amputation. So by which method will you do it, when to do it and how to do it? Success and failure is a 7-letter word, depends on the surgeon who decides what modality he is going to use. So normally when I have a patient with infection with stage 3 and 4, when hindfoot, midfoot both involved, I choose ring fixators because it's a single solution for the whole problem. So one for all is my way of handling it. It has got a high success rate, better limb salvage, early weight bearing, you save the limb. So this is one of the cases presented to me like this. That is the X-ray. So 2-3 centers said you can go in for amputation, below knee amputation. So we took him for debridement. Then I took him for a Elizarov. Here you can see his walking video. Normally I put on a transcalcaneal pin. Pin is removed in 4 weeks. Then I allow them to walk. So this is another case. It went to heal fully and he is walking with a fibrous union. There is another case where patient went in for a TTC nail, got infected. That is the X-ray. And 2 times they have done a debridement elsewhere, but the infection did not heal. So I had to remove the nail, then plan for a ring fixator. You can see the lady is walking now with the crow walker. Rings have been removed. All my patients where I remove the ring, I put them on crow walker for 1 year. Because I accept fibrous union also. There is a track of about 64 patients that I have done by limb salvage. None of the patients went for amputation. Normally the transcalcaneal tibial pin is removed in 3 weeks. Partial weight bearing was allowed after 3 weeks. Transarticular compression every week was done for 8 to 10 weeks. My average time for a fixator was about 7 to 8 months. I dynamized the ring about 3 weeks prior to removal. 4-foot ring removal always done prior so that the breakage of metatarsal wires are prevented. Antibiotic cover is normally for 6 weeks or I take a ID specialist opinion. All patients were on bisphosphonate unless otherwise contraindicated. All patients are on crow walker for 1 year. So solid union with a Charcot foot in Elizarov, the success rate is very high compared to a TTC or a plate and screw fixation or even in a beam screw fixation. The internal fixation has its own limitations when you compare it with the Elizarov. Fibrous union also is accepted because you salvage a limb and patient walks comfortably with that and they don't come back with any other complaints. The main aim of doing a Elizarov is plantigrade foot with non-ulcering food is very, very important. It's still a good option. Ilizarov is a very good option. Overall complication rates on ring fixator is about 25%, whereas 41% in internal fixation. So I would always choose a Ilizarov fixator as one-time solution for Charcot. And all the patients, 96% are ambulatory limb in a Charcot. Thank you.
Thank you so much.
I would like to show our experience of treatment diabetic foot using by Ilizarov method. So, in our experience, middle age of patients have something around 15 years, and all of that patients had a high weight body, more than 31 degrees. So middle time of sugar diabetes before our treatment was around 9 years. And in a time when patients was admitted in our department, glucosylated hemoglobin was more than 7 and 22%. Middle time of Charcot food before our treatment was 189 days. It's middle, something around 6.5 months. And the typical local view of our patient, which one we treated, looks like that. What does it mean? Ulceration, scars, deformation of the foot, and of course of the bones. So that diagnostic protocol we used in our practice. The protocol include basic blood tests, of course test for glucosylated hemoglobin, vitamin D test, ultrasound scan of vessels, X-rays of feet on for position, for understanding which kind of deformity the patient is have, MRI and CT scan, and of course culture test. So X-ray picture and all patients which were admitted in our department have troubles and by Eichenholz scale. First type of Eichenholz scale was 12%, second type 42%, and third type 46%. By Sanders scale, patients which one was admitted in our department actually have a third and fourth type of Sanders scale. And that means that actually almost patients which one admitted in our department have troubles with midfoot and hindfoot bones. So protocol for medicine treatment include correction, of course, glucosylated hemoglobin, syrup of comorbidities, very important here. Treatment of osteoporosis by using vitamin D, bisphosphonates, and other drugs for treatment of osteoporosis. And of course treatment of neuropathy, because that's very important for follow-up after our treatment. And of course correction of blood and supply disorders. So surgical protocol include especially sequestered necrectomy and external fixation by Ilizarov. Aims, which one aims of Ilizarov for treatment Charcot foot? deformity correction, reposition of the bones fragments, recovery of the bones defect, creation of functional stability of the foot, and offloading of plantar surface for healing wound ulceration. And our decision of external device for charcoal foot, in our opinion, should be have a hybrid half pins and wire construction. Distance between half pins and wires should be minimum 15 millimeters on the leg. Minimum, that's important for prevention some pin track fractures or some complications around half pins and wires. And the minimal distance between internal side of rings and surface of skin on leg should be 15 millimeters minimum, because we know, everybody knows that diabetic foot have inflammation of the skin in iliac frame, and kind of hybrid half pins and wires construction on the calcaneum. I showed it yesterday. Offloading of plantar foot in case with ulceration. We use it. We using that kind of parts for reserve offloaded. It's plastic. It's not have a high weight. Changeable size of frames on foot. And antibacterial therapy protocol here is very important to use it neurotoxic antibiotic drugs for protection some complication with nephrotic system. So, and kind of how we take a tissue for microbe test and histologic test. So, is some examples. Female, 54 years patient was admitted in our department in that local index review. Was done sequestral necrectomy and reserve osteosynthesis. Was done compression, and total time of fixation was 6 months, and 1 month after removal device, good result. Of course, she had a shortening. We're talking about lengthening with that patient, but she didn't want to do it. And follow up 5 years after removal device, result is safe. She didn't have recurrence of infection and some other troubles with the foot. Female, 56-year-old patient. She was admitted in our department with that local view, with third type of some of the bone deformity pathology by the Sanders scale, and second type by Eichenholz. Was done sequestral necrectomy and Elizarov osteosynthesis. Was done compression between bone fragments. Good result. Final result after 1 year after treatment. She walking. That view first or second day, I don't remember exactly. After removal device, she can walk. Good walking. So another one patient was admitted in our department with that local view and X-ray view. As you can see, he treated before us, but unfortunately unsuccessful. Was done sequestral necrectomy, debridement, and osteosynthesis by reserve. Good result 1 year after treatment. So actually we used treatment protocol for Elizarov fixation time. First 2 months total offloading of the pressure for the on the reserve fixator, and every 10 days we give to patient 1 millimeter compression. On the third and fourth months, patient can walk with a little bit pressure, something around 25-35% on his foot. And on the 5th month, we take manual test for bone consolidation, and if we understand that patient have a union of the bone fragments, we make a removal device. And after removal device, we make for patient for 2 months minimum brace or cast for fixation, and we.
Can you wind up?
Sorry, I will finish. Yeah, and cast and walking with 35-45%. So, and result of treatment, in our opinion, in our practice, is much good. Nobody make an amputation of the foot, and whole message. Combination of Elizarov philosophy, sequester necrectomy, antibiotic drugs, and therapy of comorbidities is provided a success in treatment of Charcot foot complication of chronic osteomyelitis. And I hope to invite you in Elizarov conference in June. Take a picture of that slide. Thank you very much.
Thank you, sir. With that, I'd like to...
For President Qin. She also want to come here, but it's pity and he can't. So I made it for her. I'm sorry about it. The topic is Professor Qin is the Qin-Zihe surgical method combined with the Elizarov technique to save the 56 cases of foot ankle deformity for amputation. All these cases is from the 2010 to 16, about 6 years. All is 56 cases. This is detailed information of the patient. For this 56 patient, they are the hemimelia 6, and trauma secular 33, and spinal bifida 12, and some lower limb vascular disease is only 5. This is all these cases was recommended by the big hospitals for the amputation. This is all cases. It's a different kind of the deformity. It's very severe, and they go to the many hospitals, and they're suggested to make amputation. For the Qin-Zihe surgical method, it is a minimal invasive combined operation, osteotomy, and partial correction of deformity during operation, and also the skin carefully incision, and they use the Elizarov technique for correct the residual deformity of the operation. This is one is 20 years old. When he was 3 years old, he has trauma, and he has trauma sequela, and we can see there's no muscles. This X-ray, you can see it is short deformity, and also with ankle deformity. The operation was multiple ostomy, and involves the Elizarov technique, the frame. And then we checked the configuration of the external fixator. And later we tracked the shift deformity of the ankle joint. the video is complete. This another case is the spinal bifida. Because of the repeated infection and the bone was absorbed. It is the 26 years old male and refused amputation, and the medical information you can see. And this is the spine. You can see the defect on the spine. And this is the ulcer on the back of the foot. And we mix the EDAF technique also with the ostomy, triple ostomy. And also with this is not with tendon transfer. Okay, it is the tendon transfer of the posterior tibia and multiple longus tendons. And after 2 weeks, the radiculiform ulcer wound was clean, and 25 days the deformity was corrected and ulcer healing. It's 110 days after operation, the external fixator was removed and they are supposed to run. As 2 years follow-up, you can see the deformity wasn't happened again. This is full. This is another cases. Okay, this is only work, and some other cases we can see it is also with good blood. This is before operation, and he worked with his back of his foot. And 75 days after operation, the deformity was corrected. This is X-ray, and this is his foot appearance. And this 16 months after operation, he can work. Five years later, after 5 years follow-up, this is after 5 years, 7 months follow-up. There's another cases that is 39 years old. It's also club foot. This before operation, and 75 years after operation.
I think that's the same case you're presenting. It's the same case. You have to go to the next one.
Okay. Okay, this is Qing's natural reconstructive theory, and the treatment result is 57 cases. Average follow-up time is 44 months, and the all deformity was corrected, and there's no serious complications. The result, this Qing's surgical method with the EDAF method can successfully treat the
1 minute
deformity. Okay. This book has been published. If you have interested, you can read this book. This is the Qing's innovation and experience insight. This is in Mexico. In Mexico, the 5th the Congress World Congress of the Asami and the International Limb Listening and Reconstruction Society. The conference will be held this September from the 17th to 22nd. Welcome everybody and welcome friends to Beijing for conference. Before the conference, we call for the papers. This is an essay paper, and essay journal is called the Orthopedic Surgery. You can publish your papers to us. Thank you.
Thank you, sir. With that, we call upon Dr. Arya Agarwal, sir, for his presentation on neglected clubfoot based on the Ponseti technique.
So, there are many methods to correct the neglected clubfoot, but we have authorized new technique based on Ponseti technique. Before we correct the deformity, we should know what are the deformities. There are three planes: frontal plane, sagittal plane, and horizontal plane. So deformity in the frontal plane is there is a pronation of the forefoot. The kite was mistaken. He was telling that you have to do the more pronation. So there is pronation of forefoot in comparison to hindfoot. Number two, we see the horizontal plane. There is an adduction of the forefoot. And in the last we see frontal plane from the back, there is a varus deformity from the head. So we have to consider these deformities before correcting the clubfoot. And in the equinus is the last. So equinus and equinum cavus. So we have modified the treatment from 0 to 2 years, Ponseti corrected cast. 2 to 5 years, we have developed a new technique, MICC, minimally invasive cast correction, and more than 5 years, Elizara based on Ponseti principles. What we do in 2 to 5 years, that is MICC, first of all, the most notorious is the plantar fascia. And there are two things are tendo-Achilles. So what we do, first of all, we do the plantar fasciectomy, then plaster cast, and the last percutaneous tenotomy. This was a boy of 2 years and 7 months. So what we have done, this is the percutaneous, that is done under local anesthesia, plantar fasciotomy. So you can see the result after the plantar fasciotomy. Then we have given the plasters and we have done the percutaneous. We tell you, we never opened the tendo-Achilles in the last 30 years. Never opened. So this is the percutaneous tenotomy. You can see the fantastic results after the plantar fasciotomy and tendo-Achilles tenotomy. Another boy, 5-year-old child with a neglected foot. In the same procedures, we have done the first plantar fasciotomy. Then we have, I tell you, as soon as you do plantar fasciotomy, most of the deformities are corrected. And in the last, we do tenotomy, tenotomy. You can see the fantastic plaster plantigrade foot there. Sometimes we have adduction deformity, we correct with the Elizara technique. So 6-year-old child treated with the plantar fasciotomy and tenotomy. We recommend correction of the Elizara external based on Ponseti principles more than 5 years. So what happens? Mostly people are doing posteromedial release. There is abundant scar tissue, that causing the recurrence of the deformity. All over the world, calcaneus is fixed with the wires, but in principle, we do not fix the calcaneus. So, abundant scar tissue formed after surgery lead to defect in fibrosis. Ligature of sternum can be used in older children. So, step is the same, positive pronation of the forefoot, metatarsal adduction and heel varus. This is a very simple technique. We apply 2 rings below and 2 rings above that, fixed with the K wires. We have, before starting the treatment, we have done the cadaveric study of the club. So, where is the question is, where is the wire? In the 180 we put the thumb, so we put the wire, olive wire, on the base of the head of the talus, and then we correct the deformity. So what happens, first of all, everything we distract, so the soft tissue becomes supple. This is the basic principle that when you correct the deformity of the clubfoot, first of all you do the distraction, then rotation. This we are showing how the rotation is done there. And after that, when we have corrected the pronation deformity, you should change the frame and we do adduction deformity is corrected. You can see like this diagram there. And we have done the cadaveric study. As soon as we correct the adduction, the varus deformity will be automatically corrected. This is the cadaveric study which we have done there. Correction done in the last after achievement of adequate adduction frame configuration is changed. We always do percussory subtotal tendocleston, wheel lengthening is done. So this is the picture of the how we correct the equinus deformity. This is a girl, 17 years. Mind you, we do not do any bony surgery except in the neurogenic cases. So what we have done, we applied the frame by same principles. And you can see that this was a very severe equinus foot. No bony surgery was done there. And gradually we have distracted the joint. And this is the final picture of the girl. Fully plantigate foot has been achieved. Another 9-year-old girl with the same technique, fully plantigate foot has been achieved there. Another girl, 12-year-old, corrected the deformity. Another 18-year girl with the deformity is corrected. It's a neurogenic foot, you know, it's a very, very difficult. In neurogenic foot, we do bony surgery, otherwise we do not do bony surgery at all. So, gradually we have, this was having meningocele, so gradually we have corrected the deformity, applied the frame, and we have done the osteotomy and removed the wedge of the condylar side, talus as well as calcaneus. So you can see the final picture. Deformity is fully corrected. You can see the walking with some support there. So this is my book of the Ponseti technique. All over the world will now not available. All over the world, even the Baltimore Post, they distribute this book. And this book was presented to Ponseti, he recommended the book. So period of study was 2000-2018, 0 to 2 years Ponseti cost, 0 to 6 years MICC, more than 6 years with Elijah. Ponseti corrected cost is now the standard treatment of clubfoot 0 to 2 years. For neglected clubfoot more than 6 years, we recommend Elijah based on Ponseti prescription, which should pass through talus, not calcaneus. We are studying clubfoot, probably the largest in India, we recommended. That open surgery is always obsolete in clubfoot. You know, I have done a lot of free camps with the clubfoot in various parts of North India. Then I learned the technique. These are children with that. Thank you very much.
in your series where you save Charcot's foot, before you touch them or you operate on them, do you do some investigations to document the vascularity of the foot?
Almost CT angio itself I will do before taking them. If suppose they have a peripheral vascular disease, they undergo angioplasty, I take them for surgery 14 days after angioplasty. It is not immediately you can't take, you'll have to wait for 14 days. That's a protocol the vascular surgeons give you.
Have you ever tried distraction histogenesis?
I've tried in some cases, but when angioplasty is possible, I do the angioplasty for the wound to get healed, then I take them for surgery.
Okay. At the end of your treatment, do you repeat a CT angio?
No, all the patients are followed up with the vascular surgeons. There are cases where the vascularity has decreased after 1.5 years.
Because of no control of diabetes.
Diabetes. And half the cases, when I take them for surgery, I see to that their CRP comes down, HbA1c comes down. Only then I take them for surgery. That's my indication for a surgery. If their CRP is too high and HbA1c is more than 12, I don't touch them.
So I think you have to highlight this point to the audience.
The other reason that you have to locate the blood vessels, one is the vascularity, other is that when you're doing a chronic Charcot foot reconstruction, you have to actually mark the pathway of the dorsalis pedis, because that course is very abnormal. So when you're trying to do your osteotomy, you have to know where your vessels are. That is another reason you need to do a pre-op study. One is for the vascular, but in Charcot generally vascularity is not a problem because it's a hypervascular state. But you know, if you're suspecting a ischemic foot, yeah, that's a different story.
Telling it that it is the Ponseti principle, because Ponseti is supination, your abduction and equinus. In this method, Ponseti is elected, original Ponseti technique, and illegal you are only doing the talon, pulling the talons to make the talon reduction.
Except the neurogenic foot.
No. Oh, sir, why you are calling it Ponseti principles?
Ponseti principle is because during the correction, we do not fix the heel till the adduction deformity has been corrected, and we put the olive wire at the base of the talus, as in the Ponseti we put the thumb. So what is our principle is that gradually we correct the, first of all we do plantar fasciectomy to correct the pronation, and after that pronation we correct the adduction. By that, as the Ponseti you put the thumb, we put the olive wire, and gradually we bring that abduct. Till now we do not fix the calcaneus, and after that when the adduction has been corrected, we never open the tendoachilles. Either we do VY-plasty. Because our 30-40 year experience, never open the tendoachilles. So this is based on Ponseti principle.
I'd like to call
Rizwan from Bangalore. I thank the organizer for giving me the opportunity here. My topic today is, I think it's a repetition, ankle arthrodesis using Izaro. As we all know, it's a surgical procedure that induces fusion of the two or more joints with the objective of improving the pain, stopping the disease evolution, or providing the local stability. In the history, Albert is the one who started this in 1882. Charles, as we all know, that he was the one who described the compression of the ankle by uniplanar external fixator. Charles fixator is the one which we all know about in the beginning. There are many indications: advanced ankle arthritis, post-traumatic arthritis, congenital neuromuscular disorders, and even in case of infections where you are not able to put internal fixators, and in case of avascular necrosis of talus. Also in advanced posterior tibial tendon dysfunction, Charcot neuroarthropathy, salvage procedure for failed total ankle arthroplasty. There are various surgical methods: conventional open surgery with internal fixation, arthroscopic approach with denuding the articular cartilage, interposition of bone graft with screw fixation, intermediate fixation, cross screw fixations, IM nailing, plating, and X-fix. These are all various methods used for the ankle arthrodesis. But goal of the ankle arthrodesis is pain-free plastic grade foot. We need a neutral flexion extension, 5 degrees of external rotation, 5 degrees of valgus, slight posterior translation of talus under the tibia. Whereas an anterior translation of talus is not acceptable. These are all the less optimal situations for internal fixation, wherein post-adult skin infection, deformity, dimple discrepancy, deficient bone stool, obesity, diabetics, all these are the less optimal situations for internal fixation. In Izaro, we all recommend because it's minimally invasive. Immediate weight bearing is allowed. Because it's a circular frame, its stability in different planes are easy with a compressive force, increases the chance of healing. Then when we use the thin tension wires, it allows for fixation in small bone fragments, especially in osteoporotic bone. And it avoids internal fixation in presence of history of infection. Minimal incision can be used. Acute or gradual correction of deformity can be done. Utilize the open wedge correction, avoiding need for bone resection. Large deformity corrections can be done. And post-operative adjustability is the most important in almost all these cases. Simultaneous lengthening is possible. Avoid multiple level treatment. Allows multiple level treatments, and weight bearing is allowed. Surgical techniques. I'm not going into the detail of it. Initially, we have to get the ankle approach in open fashion. Joint has to be prepared. Remove all the remaining cartilages, fibrous tissue, correct the deformity. And wedge excision, whatever necessary excision has to be done. And position, we normally prefer putting 2-3 KYs to help the position in the proper before putting the rings. Then comes the tibial-talar fusion. In the absence of segmental bone loss or hindfoot deformity, simple compression arthrodesis can be performed. Initially, we put 2 appropriately sized rings on the distal tibia. And third ring, or alternatively half ring, then fixed parallel to the distal tibial ring with 4 evenly spaced compression rods. Foot is then properly aligned. Half ring is connected to the calcaneus and talus with 2 1.5 mm wires in the talus and 2 1.2 mm wires in the calcaneus. Ankle is compressed 2 cm intraoperatively, followed by 1 cm per week until fusion occurs. If there are other deformities, whether there is a forefoot, midfoot, hindfoot deformities can be there, it must be corrected before the ankle compression. Tibio-talar compression, while applying a corrective force to the forefoot, midfoot or hindfoot, will prevent correction of these other deformities. So all these can be corrected intraoperatively. If not, the tibio-talar frame can be modified with hinges, derotation or transport systems to correct the varus valgus, rotation or alignment problems. If there is a shortening or segmental bone loss, we can go for bone transport can be accomplished. Normally, metaphyseal corticotomy in the proximal tibia is done, and tibia is lengthened where the defect in the angle is closed, compressed. These are the two methods. One, we normally dock before and then go for lengthening. Second one, bond transport method. These are the two methods used for lengthening it. So, Elizarov frame considerations. Frame should be applied to the leg so that the rings are perpendicular to the bone axis. Rods are parallel to the bone axis. And there is adequate clearance between the soft tissue and the rings, especially at the posterior leg. Any frame modification can be done intraoperatively and postoperatively. Some of the papers where retrograde IOM and Elizarov external fixator both yielded better union for tibial arthritis with Charcot neuroarthropathy, but Elizarov had a greater union rate. In this case, there was sound fusion was achieved. Infection was controlled in these cases. Ankle arthritis using electrotechnique, high fusion rate with no major complications. In this paper also there is high union rate, early weight bearing is allowed in these cases. So first case, where 60-year-old male, so went for 3-ring construct, 2 tibial ring and 1 in the calcaneal part, talar part. Patient was made to be ambulant and it went into a very good union. It's after the frame removal. It is a second case. There is a 60-year-old male. Initially he was treated by just pinning, tried to get arthrodesis, but almost talus is fully gone. Only bits and pieces of talus are seen. I put a 3-ring in the tibia and 1 in the distal part. This is a frame. Patient was walking around with the frame and went for a good consolidation. Post removal, this is a good union which we achieved. So another case, he was a very 36-year-old male, diabetes mellitus, very high creatinine was there. Initially treated by external fixator. Then when patient came to me, I have put a ring. And after 2-3 months, I added another ring proximally and corticotomy done proximally. Distraction started. Finally went into a very good union in the proximal particles and patient is ambulant now. This is another case with tumor where they have done a plating with a fibula, but that went into failure. It had a fracture. And patient, I have put her on Elizarov, and proximal corticotomy is done and lengthening also is done proximally, and finally went into good union. So take home message is ankle arthrodesis is difficult situation using Elizarov technique with a high fusion rate. And early weight bearing is allowed with no major complication and operative failures. Apart from providing dynamic compression across the fusion site, added advantage of Elizarov is adjustment that can be made in the fixator in the postoperative period, so that we can correct any errors that could occur during surgery. Based on these facts, Elizarov arthrodesis is recommended for ankle in difficult situation and presence of multiple complexities. Thank you.
Having gone through the program and seen that there are more than one people speaking on complex foot deformities, I slightly modified my talk. So you've already seen some of the congenital deformities like the CTEV and the post-infected ones. I will restrict myself to the post-traumatic deformities, right? And importantly here, we will learn to understand the key components. Because when you have a deformity like CTEV, that is along the expected lines, right? Unless someone goes in, does surgery, changes anything. But post-traumatic deformities can come in all sorts of varieties. And unless you understand all components of the deformity, you cannot really do a good job of correction. So having done that, you should be able to formulate a treatment plan and then follow them up meticulously. So to make this very, very crisp, I will show you only 3 cases, but I hope that we can discuss some of the important principles. So the first one is an equinocabovarus foot, but let's look into the case. Something more than that. So this is a 23-year-old female who had an accident when she was an 11-year-old girl, operated elsewhere, Typical Indian scenario, no records available, no x-rays available, but that's what her leg looks like. So you can see an obvious equinus deformity. You also see that big medial crease over there, something similar to a club foot, which indicates that there is an adduction at the level of the midfoot. You can also appreciate the varus. In addition to that, she has a limb length discrepancy and she also has a valgus malalignment. So this is not really a garden equino-cavo-varus foot. You need to be able to pick up all the deformities, all the problems that are present in this patient. This is how she walks, which is pretty bad. Okay. So when you look at the x-rays, the one on your left is actually an AP view of the foot. Doesn't look like an AP view of the ankle. It looks somewhat confusing, but it is what it is. So you will see that there is a fused ankle. Whether this was surgically or whether it was an open wound that fused spontaneously, we don't know. On the other side, you will see that all the metatarsal heads are in line. The foot is plantigrade, but look at what is happening to the injured foot. The foot is actually in supination. So we need to be able to pick this up and we need to be able to address this if you want a plantigrade foot. So looking at the lateral view, you can pick up the equinus deformity very easily. But look at the Meares angle. At the normal side, the lateral Meares angle is pretty good. But what is happening here is that the first metatarsal is elevated, and in a normal lateral view of the foot, you would see a significant overlap of the metatarsals. Here you are seeing all of them individually. What does that indicate? Well, again, the forefoot midfoot block is in some amount of supination. So the AP view of the foot looks actually like an oblique view, and the thing to appreciate here is a significant amount of adduction deformity, as indicated by the increased Meares angle. The hindfoot alignment view, so this was an older case, now we try to get a swordsman view in all the cases, is not much contributory because of the abnormal position of the foot, but it's there, we should do a meticulous workup. So the CT scan confirms that the ankle is fused, the talonavicular joint is fused. Perhaps somebody tried to do a triple fusion that ended up in a bad position like this. The subtalar joint is maybe dicey, maybe fused, maybe fibrous, whatnot. Then let's look at the 3D pathoanatomy. So the equinus is pretty obvious. Varus is pretty obvious now that you look at it. And importantly, you are able to identify the supination of the forefoot block and also the adduction. So we pause here to think about all the deformities that brought about this case, and what do we do? How many people would do a revision ankle fusion? I know that there are some very experienced surgeons in. Show of hands. Okay, revision triple fusion. Come on guys, you got to say something. You have to select something. Osteotomy. Okay, Dr. Wilfred, what kind of osteotomy?
If you go question wise, your patient is walking pretty comfortably without pain. So why touch the...
It looks like she is walking comfortably, but she was in a lot of trouble.
Yeah, she's in a lot of trouble because of the walking on the lateral border of the foot, not because of the ankle problems.
Yes.
So why touch the ankle?
Agreed.
Okay. A triple fusion. Well, what are you going to achieve with a triple fusion? So it's rather you solve her problems rather than you correct her deformity aesthetically. So like you said, she has problems walking. Yeah. So if you give her a osteotomy, okay, a very simple osteotomy of the in the region of the midfoot, correcting only her supination. Okay, and maybe at the end of the correction, of course, you will obviously be holding it with temporary K-bias while you do the osteotomy. You can revisit the hindfoot and see if that is kind of plantigrade or it requires a calcaneal osteotomy to slide it down a bit.
Yeah. So, but we do agree that this is a rigid foot, and just like in a club foot, correcting the forefoot would correct the hindfoot. That's not going to happen here. This is a fused down foot, and you need to address the calcaneal component and the midfoot component.
But I would look at the calcaneus after performing the midfoot osteotomy.
Okay, sure. That's one way to go at it. Thank you. So, what did we choose? And for the sake of time, I will make this short and sweet.
Exactly what I was saying.
Yes. So, we chose both of your osteotomies, but in one go. So, the Elizarov V osteotomy is a pretty powerful osteotomy. It allows you 3-dimensional corrections of the foot. And this is just a simulation to show you how it works. So, you can go ahead with this osteotomy with a gradual distraction. Get that calcaneus out of equinus and get a good regenerate over there. With very good placement of your hinges and differential rod distraction, you can gradually correct the supination. You can also do it a little bit acute and a little bit gradual. And then, of course, by again differential rod distraction, you are also able to correct the varus deformity. So this 3-dimensional correction is possible, which is what we did. Now because of the bad scars, we chose this modified sinus tarsi kind of an approach. You can see that the V osteotomy was done. And then this is at the end of correction. So remember, she also had a valgus. So with the same frame, the mechanical axis was also restored. We were able to get our osteotomy done. You can actually see the regenerate right here, right here and here. And that is a comparison of the pre-operative and post-operative x-rays, the walking. Okay, so for the sake of time, I'm just going to show you the second case and end with this. So this is a planovalgus sort of a foot. Guy comes in after a road traffic accident, managed non-operatively. You would appreciate the forefoot abduction and again rotational or a torsional component of the foot. So this was a midfoot dislocation which was neglected. And the problem here was a short lateral column with an over-lengthened medial column. So, unequal column lengths. So what we did here to do a Elizarov frame, lengthen the lateral side, compress the medial side, which is what was done. This approach was taken, osteotomy was done. The frame was used to create a lengthening on the lateral side, and interposition grafting was done. And at the end of it, you can see now that we've got equal column lengths and a plantigrade foot. So now because I have already run out of time, I'm going to end this and actually come on to my last slide here, right? So what is the take-home message? I hope I can impress upon the youngsters to have a very careful evaluation, meticulous planning. You have so much these days, 3D modeling, 3D printing. Please make use of all of this. Identify all components and address them, and be sure to follow them up meticulously. Thank you.
This time, Asami gave us the IFAS, this opportunity to work together. We take this opportunity and welcome all of you on behalf of Indian Foot and Ankle Society. Here I present a case which actually changed my thought process on Elizarov surgery. It was did almost 9-10 years ago when I just completed my initial fellowship of Kurgan, and I came back. So in my clinic, I straight go to the case, a male daily labor of 25 years, history of fall from 40 feet above, and admitted in a hospital initially with open injury. Initially patient was not came to us. So this was the patient initial information, and he had compound comminuted fracture talus and calcaneum on his left ankle, compound fracture on distal fibula and medial malleolus of tibia over right ankle. But he was hemodynamically stable, and post injury I got this X-ray from the patient. This is a right AP and lateral, but it is actually compound in nature. Initially there was no clinical photograph, and this was the only X-ray I got at the time a post-injury X-ray of the left lateral region of the left ankle joint. So here you can see also there is a crushed injury of the calcaneum. The posterior part was open and there was a contamination. And the initial management given by initially an orthopedic surgeon with wound debridement, thorough wash, and put some care fixation of the both ankle with POP back slab. And this was the first post-operative X-ray of the right ankle, which was initially treated by some other surgeon, and this was the initially post-op X-ray of the left ankle with VAC procedure, with some VAC procedure. So this was the things, and patient initially told that there was a repeated wound debridement taken during the procedure. So patient came to us with this situation. So hugely infected, right as well as left, and patient basically came to us for the amputation. And the different 3-4 surgeons already told that it should be amputated, and patient body was also very much scared. And the patient counseling is very much important in this situation. Already 3 months already passed. There was a huge monetary expenditure as well. And this is the common scenario in our society, in Indian society, where the poor people came to us with this condition. So this is the things. Already 3+ months passed. Patient and patient family members were confused. Infection not controlled. They were in dilemma whether amputation or salvage. So we take our challenge and we plan favor of salvage. There is some questions how we proceed, what are the treatment options, what kind of implant we use, and when we will do the surgery. So this is the on-table picture. We did simultaneously right ankle as well as the left ankle. Right ankle, thorough wound debridement and infected bone, all infected bones have been removed. Left ankle also, you see there is a hollow portion and thorough debridement, dead bone, all the dead bones we removed. And we go for the right ankle, this Charlie fixator for the right portion, after doing that the huge debridement, and put the Elizabeth ring fixator on the left one after doing that debridement. And 1 day after, this is the post-op X-ray of the right ankle joint, and this is the post-op X-ray of the left ankle joint. So initially we make the patient out of infection, and after 6 weeks, we did plastic flap coverage on the left ankle by our plastic surgeon. During this whole period, we used normal saline dressing only. Nothing we used, only go through the normal saline dressing. And removal of Charlie fixator on the right ankle after 2.5 months, and put in the plaster of the right ankle, and remove the external fixator from the left ankle after 4 months. And here is the clinical picture post-operatively, and here is the clinical pictures post-operatively. Patient can walk. there is a little bit of pain, but ultimately we can salvage the leg, foot as well. Without support, patient can walk comfortably. Here is the latest X-ray of the right ankle as well as the left ankle joint, and patient can stand. So very important, after doing this case, we thought that the patient counseling is very important, as the patient came to us with huge expenditure, and they are not sure whether we can salvage his leg or not. Control of infection needs massive debridement, thorough wash, proper instrumentation with minimum soft tissue handling. Whether you use the external fixator, here we definitely go for the elysial fixator because it do magic. Judicious use of antibiotics, everyday follow-up, assure the patient and his family proper post-op rehab. Thank you, and I also request everyone, please come and join with us in the Asamicon 2024 in Kochi from 22nd August to 24th August this year. Thank you.
Thank
you. Your colleagues, the technique which one I will show now, very interesting, and now in that year more than 30, the technique have more than 13 years of from the time which one the technique was created. And about the technique we wrote a lot of cases, and that's on that slide some from that cases in international journal from the last time. So actually we was treated with using of that technique more than 25 patients. All patients have infection, of course, ulceration on the plantar surface, and total hand-foot defect. And we separate for all of that patients on the two groups. One first group, total calcaneum defect, and second group, calcaneum and talus defect, actually total hand-foot defect. So method for treatment of the group 1 with total calcaneum defect. First stage includes arrest of infection, radical sequester necroctomy, ulcer wound stitching or plastic wound, elysial fixation, and antibiotic therapy for 2 weeks. On the second step, on the second stage for that group, we was done reconstruction of the foot. First step was done ankle arthrodesis with fixation in the reserve frame of ankle in 1 month. On the second step was done reconstruction by extraction of the proximal side of tibia and talus neck. Then after that was started lengthening, tibial transport, and as a second step, step 3, was done transposition and rotation of the distal fragment backwards after distal tibia, or something. It was something around 10 or 15 days. And some example. A female patient, 25 years old, with spinal trauma in 2008, with ulceration on the and fistulas on the plantar surface and total wound defect of the calcaneum. First step was done debridement, osteosynthesis, and second step was done arthrodesis of the ankle joint in the reserve frame. After 1 month was done tibial osteotomy in the proximal side. lengthening them in postoperatively, and when we create enough space of tissue, enough tissues in the hind foot place, was done osteotomy again in the distal side of tibia and making tibial turning, and follow up more than 5 years now. Patient have a good result, not recurrence of infection. Another one case, patient with that local view was admitted in our department. That video, how does he walk before treatment, important that he was admitted with osteomyelitis on the right foot. So first step was done sequester necrectomy, osteosynthesis by reserve, osteotomy, and final result. Patient can walk without some support, without some special shoes and soles or something else. We treated right foot. Group 2 with total hind foot bone defects, talus and calcaneus. First stage arrest of infection, second stage reconstruction. Here is in that stage we didn't do ankle joint orthodesis because ankle joint was a total defect of ankle joint. Important in that case that it is the first patient which one was treated by Elizarov himself in 1989 year. Female patient was admitted in our department with total hind foot defect. Was done sequester necrectomy, osteosynthesis, then was done osteotomy in proximal side of tibia, bone transport, and then again in distal side of tibia, osteotomy for creation new calcaneum. Good result. Another one, same patient, female patient, after a gunshot injury of the hind foot, was admitted in our department with that local and X-ray view, was done sequester necrectomy, osteosynthesis by reserve, and then reconstruction stage, proximal side of tibia osteotomy, and in distal side, then after bone transport and osteotomy in the distal side, and creation new calcaneum. Good result, more than 5 years now, and follow up. Patient can walk without some supporting, without special shoes, without something. So, and results. Infection was arrested in all cases. Ulceration and fistulas was healed in every cases. Defect of the hind foot and the articular parts of the tibia were filled in the newborn tissue and was improved function and ability for walk. And in conclusion, calcanization is a complex method of treatment that requires a lot of efforts and time from the doctor and the patient, but at the same time allows to save and restore the function of the affected limb. Again, I am invited to in the Elizarov conference. Please take a picture of the slide. And the slide, take a picture. Thank you very much.
Thank you, sir. With that, I now...
For coming in Asamicon, especially TV fast for giving available time. Regarding the laser technique in clubfoot, RSR, Siddhartha and Rizwan has talked a lot, so I'll just focus on surgical techniques only. Thank you. So why do we need elixir and a clubfoot? To place optimal circular external fixator in a complex clubfoot deformity resulting in plantigrade functional foot. So to get a simple plantigrade foot like this in any clubfoot deformity, we have to be very meticulous and the objectives and techniques of the technique and other patients and other patients. So if you know the good technique, you can do methods with this. So let's see back to basics. Like in clubfoot is a gold club shaped deformity. Back to basics, it is like congenital talipes equinovirus. Congenital is from birth. Talipes is talus plus foot, talus plus foot. Equinus is plantar friction. Talus tilts into equinus and virus, and virus the heel goes into inversion. So we have a cave deformity. Cavus and adduction is a deformity of forefoot and midfoot, that is from the mid-tarsal joint, and weaves for virus, that is for hindfoot and subtarsal joint, equinus for equinus, if equinus and hindfoot for ankle joint. So this way I have to correct all the deformity, cavus, virus, adduction and equinus. So for cavus, it's in forefoot increased curvature of the tarsal metatarsal joint, adduction is in the between metatarsal and calcaneum, distraction across Chopard's and Lestrade joints, virus correction has to be done between TV and calcaneum, distraction across the ankle and sacroiliac joints, and equinus correction the hindfoot between metatarsals, calcaneus and tibia, rotation on the intermetatarsal axis. These are basics. So with Elizaro we can do with these techniques. For the adduction correction we can do gradually all these techniques from virus to valgus, adduction to adduction. From the plantar aspect of the same, virus correction of the heel we can do correction with this, between tibia and calcaneum, across the ankle and sacroiliac joints. Equinus correction we can do similarly from residual vertebra, placing the hinges in the right points. These are the step-by-step Elizaro techniques I learned from Kurganoti, Dr. Dennis. Similar technique I followed and did in my OT in an adult male. So this is about all correction in adult male. This is a young adolescent girl which was not getting married because of clubfoot. This is a girl with a magical smile. So we're having a step-by-step Elizaro technique in a soft one and a clinical also. So the basic steps are, we have to do, if needed, tactical lengthening, plantar fascia release, tibia rings we have to apply, then calcaneal half rings, metatarsal ostomy. If we have a flat top talus or reostomy as needed, at attractive talus, then we apply foot half ring, hinges and toe wires. So first we do TL lengthening as needed. In many of the cases, not in all the cases, mini open plantar fascia release. Then apply the tibia rings around 3 fingers above the joint so that we can accommodate the hinges like this. The tibia rings, first and second ring, and then the similar picture is the same. We have to keep some distance here, 4 fingers, so that we can apply the hinges. Just not like the typical tibia rings in any trauma. So next we have to apply to the calcaneum half rings. Cross cavas 2 or 3 as needed. Then a half ring in the foot. Then also apply a Shanskin from distally. Then we have to apply, we can do a metatarsal ostomy, mini open when we have a bony deformity. So we can do metatarsal ostomy or reostomy as needed. I've done both, but metatarsal is much easier. Then we apply the foot half ring. Then we apply the hinges, the medial hinge, the lateral hinge. We apply 2 rods above to correct the adduction. Normally, earlier we used to apply 1 rod only. So 2 rods help in the correction of both adduction and abduction, and apply the calcaneal ring. These are the animations. We'll go into the surgical steps and soft one also. These are the hinges at the level of tarsal joint. These are the corrections. We correct the dorsiflexion, we correct the abduction, adduction. These are the place of the hinges. These are very important. The placement of hinges are very, very important in any cases. You get a complete correction and complete very good movement in all the cases. These are the plantar and dorsal connectors. We apply a twisted plate. We apply male-female post and we connect with the rods and hinges. These are the plantar and dorsal connectors. And in many cases we should apply toe wires so that we get a complete correction. Toe wires are very, very important. We usually use the toe wires for the correction of clubfoot. So this gives a very optimal results. I'll show you with and without. These are toe wires in continuity. Final assembly, this is in the same way. You can see a complete correction with toe wires. So with this we can do a very good correction in all the cases, starting from Let's have a quick look at the software demonstration also. This is a typical clubfoot configuration in any software model. I'm not applied to us because there is no space in the model. So first we apply the TBR frame. So two TBR rings, distal rings has to be 3 to 4 hinders proximal to the ankle joint to accommodate hinges. We follow the rule of 2 towards each ring, connect shank screws with shank ratchet loops as needed. These are the videos of TBR wire. I'll go fast. If you cut the wires, bend the wires, we can apply shank screws also. Then apply the calcaneum frame. Then add on posterior shank screws. These are the hinges, middle hinges. You can see you have to get the complete movements. We can make universal hinges with this. So the all movements are there because we have to correct our 3D corrections there. So we try to make a universal hinge with 3 posts. The foot frame, foot wires. These are the metatarsal neck wires. We apply on twisted plate male and female posts, connecting calcaneum link to the foot ring. Like this. It's the middle one. Similarly, we make a universal joint and apply on the lateral side also. So making universal joints is very, very important to get a optimal correction. This is the foot ring to the tibia frame. Correct adhesion and reduction deformity with this. So this is the way we make a universal joint. So we get rotation movements in all the directions, whatever you want. So we have one female, one male and another female. 3 posts are there. You can make any universal joint to correct any deformity. The posterior calcaneum hinges. So which is the range of motion? You can see the range of motion, equinus and adhesion was freely movable. So this is very important. The free movement is very, very important in post configuration. You shouldn't be jammed, you shouldn't be stiff. Free movements in both the sides is very, very important to get optimal correction gradually. This is the final assembly. This is actually Professor Dennis taught me at Kurgan. We have a lot of correction from what we did earlier. So this is the step-by-step clubfoot result applications. So the take-home message is treating complex clubfoot deformity. We need to get a very good anatomy. If you have to follow the same positive principle that we do in a class or a JES or a laser or an open surgeries. The principles are same. We have to apply a good configuration. We have to follow step-by-step deformity to place optimal circular external fixator. Correct hinge placement is very, very important. Complete times is around 3 to 3.5 months. We have to put bases around 3 to 4 months. Resulting in a plantigrade functional foot. So we get a finally happy clubfoot family. Thank you. Thanks a lot.
I would now like to call
invite me here and have the opportunity to talk about my work. This work is about the diabetic foot. We use transverse bone transport for the diabetic foot, but nowadays there's some problem because some days don't be bent. For the diabetic foot, the main reason is the peripheral nerves and blood microcirculations. This is the main cause of the diabetic foot. Okay, we don't talk about that because everybody knows that. This transverse bone transport is derived from the Izarov technique. This is the Izarov discovery 315, and we can see that after bone transport, the blood circulation changed. Let's look at the cases. This is 58 years old diabetic foot. It is repeated rupture for 6 months. Is no healing signs. So this is the case. And after bone transport, only 5 days, the wound will be inflammation reaction subsided. And 10 days bone transport, the wound healed smoothly, only 10 days. In other cases, it's very severe because of the, my followers didn't find the infection behind the medial malleolus, so it has taken a long time. Of course, it is produce mirabilis infection. Okay, and the after treatment, after infection was controlled, there is a big wound on the sole of his foot. Of course, this area is quite easy to heal, but this area, this fourth picture is 120 days. The second, 1 week after 1 week later, we can see the wound healed very quickly with his own skin. Only 1 week. I just after this is more than 1 centimeters from the both sides, and it healed very quickly. Even a little child, couldn't heal so quickly. This is okay. Another case. This is a very severe diabetic foot, and also with many complications. And so this was his foot before the treatment, and the bone problem is also here. And after the bone transport, we use we make a soil debridement. You can see it healed also very quickly. It is no flap, no skin transplantation, and you can see it is healed very quickly. So we want to know why. So we did some research. We can see the cytokines, especially VEGF, FGF, have one that increased after the operation quickly. Also, the Wi-Fi classifications have changed a lot, and it has a significant statistically. And also the fast evaluation, Wagner classifications, again temperature has changed. So we want to know how is the blood supply. Of course, we can use the DSA and CTA, but this is not for the macrocirculations. So we developed a new method. It's the super macrovascular imaging. It is completely different. The upper pictures is okay. The upper pictures is the common ultrasound. The downside is the SMI imagings. You can see the blood vessels clearly. And we do the search, it's the same as before, and we can see the collateral arteries is changed. It's the new collateral arteries. These blood vessels is mostly under the diameter is below 0.7 millimeters. So it's a complete macrocirculation. Let's look at it. It is after treatment. We can see that is the left side and is before, and the right side is 1 or 2 weeks later. We can see the collateral branch that reproduced is growth. This we can see it's clearly before operation and after operation. This is the 2 months and 1 month. The left side is the 1 month. We can see it's changed gradually. The left side is ultrasound. The right side is the SMI. The second case is the same. Because of time, we quickly we can see also is changed very quickly. Third, we can see the microcirculation changed. Fourth, this is the first case, the before operation and after operation. After 2 weeks, we can see the change very good. And the fifth, 5 cases. The sixth, before and after. So, it publishes this work on the Chinese Journal of Orthopedics. This is abstract and some other papers. And we can see after transverse bone transport, the collateral circulations, macrovascular peripheral nerves improved. And transverse bone transport by osteogenesis activates vascular nerve generation associated factor expression, and also enhance the tissue repair capability. Is again welcome to our 6th World Congress. Thank you.
Thank you.
Required dorsolateral wedge osteotomy and fixing the toes to the frame with the K wires. This is a 19-year-old boy presenting with bilateral neglected clubfoot. And so I carried out plantar fascia release, open TL lengthening, capsulotomy, FHL lengthening, and he required dorsolateral wedge osteotomy followed by Ilizaro fixation. Residual deformity can be corrected by Ilizaro slow gradual correction. The osteotomy site was fixed with multiple K wires. This is a post-operative picture, video of the same patient. Though he had 3 curvatum and valgus, he was not bothered about that, but he had a painless plantigrade chewable foot. This is another patient, 6-year-old boy with bilateral neglected clubfoot. This is the post-operative picture, painless plantigrade chewable foot was obtained. All my cases at the end of frame removal, I do a tibialis anterior transfer. It acts as an internal split. So another condition, Dieter-Ford syndrome, very common. Usually they have a previous history of meningocele excision, and so this patient presented with equinovarus stiff foot with ulcers over the plantar aspect. In order to make the foot supple, I apply Ilizaro and make it supple, and then do a posterior tibial tendon transfer at the time of frame removal. This is immediate post-op, and this is 1 year post-op. Always they should wear brace in order to prevent recurrence. This is a rare condition in congenital pseudarthrosis of fibula where the lateral malleolus migrated posteriorly and superiorly. So I applied sharp spin to the lateral malleolus and dragged the lateral malleolus in its to the normal position compared to the normal limb. So this is once the brain is removed, in order to prevent recurrence, I do a TBO fibular arthrodesis. So you can see the pre-operative picture, and on the right side post-operative ankle, painless plantigrade foot. This is another patient with a lower end tibia chronic osteomyelitis with a sequestrum with equinovarus deformity. So I had to excise the dead bone and do a proximal corticotomy, and this is how the corticotomy proceeded. And at the end, I could get a good 5 centimeters regenerate with ankle arthrodesis. See the movement of the neighboring ankle joint in children, very effective. So patient is a karate player. He has won 3 gold medals in a district level karate champion. See the ankle movements. He is not bothered. There is no restriction of the movement of activity. This is another patient presenting to me with nerve injury and malunited calcaneal fracture. All the muscle power were 0 except peroneal group. So this is the X-ray of the same patient with a valgus ankle. So I did a tendo-Achilles lengthening and did a peroneus longus transfer to the tibialis anterior. Along with that, I did a subtalar distraction arthrodesis and bone grafting. So in order to maintain the position, I applied Elizaro, and this is the X-ray with good correction. See, the immediate third post-operative patient start walking on the foot, and it gives a lot of confidence to the patient. Another patient with a post-traumatic severe scarring. Patient had an open fracture. There was a severe foot and ankle deformity with clawing of the toes. So mounted a Elizaro on that patient and did a gradual correction. At the end of 3 months, you can see a good plantigrade foot. And patient never walked for 2 years. Now patient is very happy and walking. Another indication is for Vargas disease. This patient presented with gangrene of the right great toe. I did a longitudinal osteotomy and bone widening technique. This increases the blood supply of about 300%. So this is how I do, make a multiple small incisions and drill multiple holes and connect it with 3 or 4 osteotomes, as you can see in this picture. And this is confirmed, the osteotomy is confirmed by CR. And the osteotomy fragment is fixed with the multiple KVARs in a cross wire technique. And this is at the end of 6 months, a good regenerate has formed, and the gangrene is not extended above the ankle. Post-burn contracture, this is a patient, a 19-year-old girl presented with a very grotesque deformity following a burn injury. See, the patient is walking over the dorsum of the ankle. You can see in the X-ray, calcaneum is almost touching the posterior aspect of the tibia, and you can see the ulcer over the anterior aspect of the ankle with the osteomyelitis of the talus. So I did a total talectomy and resection of the distal tibia and then mounted Elizaro. And with gradual correction, I could get a neutral ankle angle. And the correction was achieved from this to this. And you can see the previous X-ray and the X-ray after correction. So I could get a TBO talar arthrodesis. Non-healing ulcer. Once you apply Elizaro, circulation improves, everything improves, and you can see a nice healed ulcer. So deformity corrected completely. I could achieve a plantigrade foot, though the foot is short, but patient is quite happy. This is another patient with a burn contracture with severe awkward bottom foot. The dorsum of the foot almost touching the anterior tibia. This is the X-rays. So around at the deformity, I applied the Elizaro in a closed manner. No osteotomy, nothing. Just do a gradual correction. I have to go very gradually in this because of neurovascular structures. So at the end of 4 months, I could achieve, I over-corrected it, and also the toes were corrected by inserting the K wires into the phalanges. This is the X-ray after over-correction. This is after removal of the frame. Patient is walking with a plantigrade foot. Charcot's ankle, another indication for Elizaro. This patient presented with failed internal fixation for arthrodesis. So I removed all the body swelling implants and then applied Elizaro. So this is ultimately I could achieve a TBO calcaneal. Most of the time we don't achieve arthrodesis, but even pseudarthrosis also is okay with this patient. They have to wear brace later on. Another patient, this patient had a crush injury with right leg agony amputation with non-union of the proximal tibia and common peroneal nerve injury. He presented to me with fixed equinovarus deformity, and I applied after SU for him in order to get a supple foot. Later did a posterior tibial tendon transfer, and this is a walking video of the same patient. See how beautifully he is walking with the processes and normal plantigrade foot. And I respect my teachers for inculcating knowledge, Dr. Milin Chaudhary and Professor Chin Sihi from China. Yeah, thank you.
I am Dr. Vikram Khanna, and I am grateful to the organizing team for giving me the opportunity to speak on managing neglected or resistant CTEV with Elizaro and 6-axis devices. The resistant and neglected clubfoot deformity presents a significant challenge. Several corrective procedures have been described with the goal to provide a pain-free and plantigrade foot. Elizarov method has proved to be a successful method in management of neglected and relapsed cases, as it has lesser surgical morbidity, better functional outcome, and also does not cause any shortening of foot as compared to the other surgical methods. The conventional thought process of Elizarov technique in managing the CTEV depends upon the distraction of soft tissues and repositioning of the foot in the corrective position once distracted. Whereas the 6-axis device which we have used is being used to gradually reposition the ankle and the foot in the corrected position, and the foot is corrected with the help of differential distraction between the heel and the foot rings. So coming to the cases, this is a 14-year-old female patient of nail patella syndrome, came with a bilateral equinocarovarus deformity. She had multiple soft tissue releases, but every time it had recurred. This is the clinical images of the patient. On manipulation also the deformity was not getting corrected, and there was scar marks of posterior surgeries seen. Right. So as you can see, the patient is walking on her tiptoes, and on CT scan we realized that the calcaneum was in quite a bit varus, and so we decided to go for a V-shaped osteotomy of the calcaneum, and along with it a midfoot osteotomy. These are the intra-op Siam images showing where a osteotomy was planned. This is the immediate post-op clinical images, post-op X-rays. Now we use the DEF-FIX program, that is a 6-axis device. We used it so that we could gradually first distract the ankle and then correct it, reposition it in the corrected position. The foot, however, was being corrected gradually with the help of differential distraction. That is, 1 millimeter was corrected on the medial side, 1 millimeter distraction on the medial side, and the lateral side 0.5 millimeters. So first was just the distraction which was done, then distraction and equinus was corrected, and heel valgus was initiated, as you can see in the left side image. Again, heel valgus was increased and equinus was corrected further, and minor adjustments were made. This is the final images, post-correction clinical images were there. So in this case, I had this one issue that I did not know the end point of correction. So I referred to this very good article by Solomon, and since it was a bilateral deformity, so I used these reference angles as the final end point of correction. And this is after 1.5 months, the frame was removed and plaster was applied. Once the patient was walking with full comfortably on the right side, then we decided to go ahead and do the surgery on the left side. However, we realized that with the midfoot osteotomy, we did not gain much, and the soft tissue, we had faced some soft issues with the midfoot osteotomy. So we just did the calcaneum osteotomy in this case, did the lengthening, corrected the rotation. The small box on the left side of your screen shows the rotation and the amount what we had to do, and the images, the red image shows the corrected position. Again in this, the pink shows the corrected position. This is the after the correction, the X-rays, and this is again after 1.5 months the frame was removed and plaster was applied. This is after the removal of the plaster. Patient is able to is little tentative but walking decently. This is I was very lucky that she came around 4-5 days back only, and we were able to get a nice final presentation. That is 8 months after plaster removal. These are the X-rays, and ankle. You can see that the right ankle has a little bit flat top talus, but I am hoping that it will recover soon. Left side, the talar tone is quite okay. This is her final walk after 8 months of plaster removal. That is nearly 1 year after surgery. Now coming to the second case, he was a right equinocaval deformity, 15-year-old male with multiple surgeries were again done in his case, soft tissue releases. So in this case, whenever I have a patient who has multiple cases have been done in soft tissue releases, then I generally avoid the soft tissue and I go for the bone osteotomy directly, because I don't want to, I feel that it may recur even after soft tissue release. Then this was the pre-op x-rays. This was the only midfoot osteotomy was done, and this is the post-operative frame applied. Again, this is post-op x-ray. This first step was a distraction, and second step was correction of the deformity, correction of the equinus, and slight lengthening was done also. Again, correction of equinus was continued. Generally, whenever we calculate a deformity, then we do it step by step, like half the deformity in one go and then the other half. Because just in case if the patient has not understood, if I have not been clear, he may rotate the struts the other way and then we may end up in a bigger problem. So then we keep the patient in continuous follow-up and we give half of deformity correction at a single time. This is the last sort of minor adjustments which were done. Now in this case, the end point of correction, since the left side was fine, so we got a X-ray of base bearing X-ray lateral view, and then 2 points I have taken, any 2 points we can take, whichever are visible through the fixator, easily visible, and then we calculate the angle of the tibia axis with that line, and then we can sort of get a good correction. This is the final X-ray, and this is the patient walking. The frame is still on, so it's a work in progress right now. So use of computer-assisted 6-axis devices gives us an opportunity to gradually reposition the ankle to the corrected position. Post-correction, the fixator is continued for another 1 to 3 months, that is depending on how much time it took for the correction to happen, followed by a plaster for 1 to 3 months. That I generally keep it till the same time as the fixator was there, and followed by a removable ankle foot orthosis for 1 to 1.5 years. The essential aspect is proper follow-up and preventive bracing to prevent recurrence. I would like to take a minute to invite you all for this CME which we are conducting in Delhi on 7th April. The link is in the QR code if anybody wants to there. It's all about HTO. Thank you.
Thank you, sir. With that, we now call.
Morning, everybody. First of all, I'd like to thank the organizers for giving a wildcard entry to this topic, and to the chairpersons for allowing me this talk. This is a distal tibial oblique osteotomy by user of fixator. We all know that ankle arthritis is a very disabling problem. It can be either primary or post-traumatic, and usually the attitude is like we keep on trying to treat these patients with analgesics and a soft footwear for long time till it goes for arthrodesis or an ankle replacement. So this new technique has been described by Professor Teramoto, which is known as distal tibial oblique osteotomy, which is actually an oblique periarticular osteotomy which extends into a distal tibial fibular joint. The fibula is not osteotomized. The opening of the wedge door with the apex at the distal tibiofibular joint increases the coverage of the talus. It increases the total contact area and decreases the load per square millimeter. It increases the stability and congruency and improves the alignment. So these are the basic principles of distal tibial oblique osteotomy. If we see the treatment modalities of ankle arthritis, there is supramalleolar osteotomy, where a lower tibial, which is not suitable for very advanced or a late stage arthritis of the ankle, and a total ankle replacement. It is very not suitable for manual workers or very active patient. And ankle arthrodesis sacrifices the mobility and can lead to the arthritis of adjoining joints. So distal tibial oblique osteotomy does a periarticular distal osteotomy the fibula is not, I'm just repeating these principles again, so it can be used in advanced and late arthritis, eliminates pain and maintains mobility, and patient can do heavy activities. So what are the indications? It is any stage of varus ankle arthritis, provided the range of motion should be at least 10 degrees. The contraindications are infection, rheumatoid, Charcot's and steroid-induced arthritis. The technique involves oblique osteotomy starting 6 cm proximal to the distal tibial joint. It starts proximal medial and distal lateral towards the center of the distal tibiofibular joint. And the wedge is opened with a lamina spreader till the talus, the lateral surface of the talus touches the medial surface of the fibula. The stabilization can be done either with Elizar or a locking, contour locking plate. Bone grafting either from iliac crest or an opposite upper tibia. The post-op protocol is an ankle-assisted exercise next day, partial weight bearing with the Elizar or fixator on second or third day, but with plate it will require 6 to 8 weeks of delayed weight bearing. The complications we can encounter is infection, wound breakdown and non-union. So with that basic background, we'll go to the first case. This is a typical case of a pylon fracture, intra-articular pylon fracture treated by plating twice. And the plate was removed and still, even after union, the patient was having a lot of disabling pain while walking. And he was having a post-traumatic ankle arthritis. So these are the intra-articular steps. You mark the entry point of the with the K-wire in AP and lateral view, and the osteotomy is done from proximal medial to distal lateral in the center of the distal tibiofibular joint. It is opened and the DTO fixation done with Elizaro. This is the follow-up at 2 months and follow-up at 4 months. This is the post-op clinical. This is a 4.5 months follow and 2 years follow. You can see the dome formation of the dome coverage of the talus is very well regained. This is post-frame removal at 2 years. There is an 8-year follow, long X-ray. See the alignment and the coverage of the talus, which is very well achieved. And this is 8-year clinical follow. Clinical follow. This is the case 2. There is a 3.5-year-old multiply operated case of bilateral POTS, and he had a lot of difficulty in walking. The walking time was only 15 minutes, standing time up to 30 minutes, and most of the surgeons had advised him ankle arthrodesis. These are the pre-op stress views, the AP stress view and the lateral stress view. And this was his gait pre-op. Now these are the pre-op IITV stress videos. You can see the stability of the instability of the talus in both the planes. So what was the protocol followed in this case? In this case, we had to remove the osteophyte. If you can see the lateral osteophyte near the lateral border of the talus, that was first removed and debrided. And once it was debrided, there was a lot of space. So the talus was totally like unstable in the ankle mortise. And after that, the osteotomy was done and it was fixed with Elizar. So this is at 3 months, 3 months post-op, just before the frame removal. And this is was after frame removal, around 8.5 months. And this is his level of activity. Just lost the slide. It is not compatible with I think it is not compatible. iPad is solid. Sorry for that. So they have just revised the intra-op steps of this surgery. It is like marking with the K-wire, the osteotomy. Then the osteotomy is done in the AP and lateral plate you mark, and then the lamina is spreaded. The whole dome of the lower tibia is spreaded till the talus touches the lateral border of the medial border of the fibula. So this not only creates the correction in single plane, but it three-dimensionally covers the whole talus. So just to summarize, primary ankle arthritis is rare that we encounter, but secondary post-traumatic is very common in our setup. We need to rethink our strategy. Ankle replacement is very costly and longevity is not poor. Arthrodesis is disabling, and DTO is very useful in such clinical scenarios. Thank you very much. Thank you. Thank you.
Thank you, sir. With that, we'll come.
You show the cases where you do the osteotomy. My first question is that, do you follow any scoring system?
Yes, we have followed. This is just a demonstration. I started doing this technique last 4 years, and most of the cases we have is now less than 2 years of follow-up. So we are just analyzing the cases.
Now, scoring
system, we have been following. The ankle and foot scoring system we have been following. But most of the time, clinically, these patients had like the walking time or standing time of less than 30 minutes. Painful.
Yeah, but right now what you told that the AOFS scoring system, I think, but that is nowadays it is not validated. The coding system is totally changed nowadays. There is a Manchester Oxford questionnaire scoring system and European quality of life. So in this kind of patient basically came to you, I think, with pain.
Yeah, with pain, and most of them were evaluated by ankle arthrodesis.
No, that is right. But the thing is that this kind of thing, this is a specific things you told here, that the osteotomy. You not mentioned that the particular level of osteotomy also. So from which particular, from the ankle joint, how much you go and how you do this, the angulation. So this kind of things, because you actually covered the, your plan is that the coverage of the talus. But in case of osteoarthritis, there is a cartilage defect. So as well as the lower portion of the talus and as well as the superior portion of the lower portion of the tibia and superior portion of the talus, both cartilages are gone. So you just cover this, and also there is a biomechanical things that the fibula you do not touch it. So when you covering the talus head with the tibia, there is also the length discrepancy. So how you measure it, how you address this?
First of all, I am sorry that the technique was described in very brief because of short of time. But I'll just go through the technique for you. The technique is that you go around, you mark a point from ankle joint around 6 centimeters proximal to it. From that, you put a gray wire from anteromedial surface towards the posterolateral and distal to the center of the distal tibiofibular joint, where the distal fibular ligaments are there. You are not piercing the medial tibia or the lateral fibula. You are right into the distal tibiofibular joint. And after that osteotomy is done, try to spread with the lamina spreader till the talus, which is having an instability in mediolateral plane, touches the medial border of the fibula. So it is tightened. The whole talar, the dome, ankle dome is tightened in 3 dimensions. So the mediolateral instability of the talus, the anteroposterior instability, and the rotational is taken care of.
I will just interrupt you here, I'm sorry for that. But in an arthritic condition, we usually expect the ankle to be stiff. Yes. So I cannot wrap my head around the concept of instability there.
Yes, see, what happens is initially it starts with instability and then the osteophytes form and the ankle becomes stiff. It is either in a medially translated.
It looked like the fluoro that you showed looked pretty stable to me. Like we've seen instability with malleolar fracture syndesmotic.
Usually
that
pretty okay. Is seen after you remove the osteophytes. Because the pain is because I think the talus is affecting those osteophytes and it becomes painful. So once you remove the osteophytes, then you can demonstrate a lot of instability.
I have another comment to make. So on the lateral view, it looks like you were increasing the LDTA, the lateral distal tibial angle. So a little concern is that the patient may have a decrease in the dorsiflexion.
No, you have to be very sure that he gets at least 5 degrees of dorsiflexion. So you correct in that way. And if it is not getting, then you have to release the DC to get at least 5 degrees of
But you are increasing the lateral distal tibial angle. So when it acts like a bony block to the talus when it is dorsiflexing.
It doesn't, it just corrects the distal slope of the tibia.
The angles which are in the frontal as well as gentle plane of the distal tibia, because in lateral view also the inclination has changed. In AV view also,
same question, sir.
but in the lateral, but I mean to say lateral view also there is change. That might lead to further arthritis.
We will ask him over a cup of coffee now.
Yes, so I would like to explain that.